Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neurorehab for SLPs. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Beth McHose is a full-time salaried employee at Lean Graphica and will receive an honorarium for this podcast. Her non-financial disclosure is that she's an adjunct instructor at ODU, Old Dominion University. My financial disclosure is that I am the owner and founder of BrainBridge Connect LLC, and I am an instructor at both James Madison University and Old Dominion University. And as the host of this podcast and other educational webinars on speech therapy PD, I do receive financial reimbursement. My non-financial disclosure is that I am the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Beth McHose, MSED, CCC-SLP, who is a speech pathologist currently working as senior manager of clinical marketing at Lean Graphica. She's also an adjunct instructor at Old Dominion University and has clinical experience along the whole spectrum of neurological rehab. Welcome, Beth. So good to see you.
Hi, thanks for having me.
Of course, of course. So today we're going to be talking about AAC, augmentative and alternative communication, and we're going to be looking into why AAC can be used for more than just verbal output, verbal communication. And so let's just dive in and talk about comprehensive language and receptive language and talk about how AAC can be a support for that. Because I think it's really out of the, I don't want to say out of the box, but I think for some people it is. Some people are very intimidated by using AAC, and I think that's one of the reasons why they just don't know kind of where to start or how to implement it.
Yeah, I think there's a lot of kind of misconception around AAC. In the SLP world, I think it's so easy to think of AAC as specifically for verbal expression, and that it is really to function as the person's voice, and we kind of forget the rest of the things that AAC can really be a support for. Like you said, there's kind of this, comprehensive communication approach. And I like to fall back on this definition from Buchelman and Miranda in 2013 about for AAC. So AAC refers to any communication strategy that is used to replace or supplement spoken expression, auditory comprehension, written expression, or reading comprehension to facilitate communicative participation for people with complex communication needs. So that says it right there, it says it right in that definition. But I don't know. I don't even think that when I learned about AAC that I thought of it like that or was provided definitions like that. Like, it was really about spoken language. And I think that's where a lot of people kind of sit and get stuck.
Well, yeah, and that was one of the things that we discussed before was that for some reason I always think that we went to undergrad together, but we went to grad school together. And so in the undergraduate program where we both are instructors, at that time when I was in undergrad, we actually took a whole course on AAC. It was taught by the AT specialist for one of the local public schools. And yeah, she went over a lot of things like that, and we learned a lot about all the components. By no means am I an expert, but I feel like I had enough to get me started, right? So I knew about like icon sizes. I knew about using line drawings versus color pictures, and just a variety of things that can be used. And I don't necessarily remember at that time, because this was 15 years ago, it was longer than that. Oh my gosh, because that was undergrad. Yikes. So several years ago,
Many moons ago.
yeah, because the technology has changed so much, even in the past, 5 to 10 years, it's markedly different. And there's more companies, I think, that do different things and provide different access methods and things like that. And I think that I would not, as a student, would not have probably thought to use it for anything other than verbal output or maybe supportive reading. But that's another area where I think a lot of people, they aren't thinking of reading comprehension or that comprehension piece of receptive language from a reading standpoint, they're not thinking about that and how we can use AAC to support that as well.
Yeah, it's interesting in the role I'm in now. So I've worked in the AAC world now for 6 years, specifically in an AAC company. And I work directly with SLPs, or I did for a large chunk of that time. And, it would surprise me how frequently I would ask about the person's reading comprehension, or reading ability in general, decoding ability at all. And oftentimes people would not know, like they hadn't assessed it. And I think that there's definitely something to be said for, if you're going to even consider thinking about AAC in the, spectrum of all of the things that AAC can offer, you also have to have a full picture of your client, and have really truly assessed all of the areas so that you can rely on strengths to support weaknesses. And like, that's such a great point. For some folks, like, their reading is good enough that is adequate as a support on their device, whether it's to find the picture that they want to communicate using, or whether it is to support comprehension, like we said, where maybe, if I'm asking a question verbally, the person's auditory comprehension might not be good enough to understand what I'm saying. But if I show them their device and show them pictures and words that either say the thing I said or provide context to the thing I said, they're going to be able to understand it. So it's so intrinsically tied to like full comprehensive assessment, which I know is very different depending on setting, and very hard depending on different settings. So I think that's just such a big piece when we're thinking about AAC.
Yeah, and it takes me back to aphasia treatment when, we were student clinicians in the clinic on campus, and we were using sentence strips, right? Those reusable, you could dry erase on them, write whatever. And we use it as a prompt for expressive language, but that was an auditory, or it was a reading comprehension too, because the person had to be able to decode what they were reading in order to fill in the blank and in order to use those written words as a prompt for their verbal communication. And again, it's a way that we've really incorporated, a form of assistive technology, just like we do with like, our calendars, our grocery lists, and a lot of that now has been converted into our phones. We mostly rely on our calendars, and I think we talked about in the original, in the OG take, we talked about how back in the olden days before we had cell phones, I knew everybody in my family's phone number, their birthdays, all that. I don't know anything now because it's all in my phone.
Yeah.
I know, like, I think my childhood phone number. It's not even my parents, my parents are deceased, so I don't to use that anymore, but why do I remember it? It's like when people ask you what your phone number is and you're like, well, I don't call myself. Let me hold a second and think about it. But we use these things on a daily basis, and most of us are not neurologically or impaired in our communication. So, some SLPs are, some audiologists are, but by and large, we're teaching communication skills. And so our communication skills tend to be pretty strong, but we're still reliant on these pieces of information that are stored in an electronic device all the time, right?
Yeah.
So
yeah.
my question is that why are people so reluctant or hesitant to, I don't want to say I guess use it, but I think and I'll let you answer the question because I have an idea of why I think it is.
Yeah. So I think there's a couple things here that are kind of interesting to think about. So depending when you went to school, and so, you and I went to grad school 15 years ago. 15 years ago, we were finishing grad school. So like, that's not even when we started. I still remember that one of our professors had an iPhone, and I was like, wow, like, she has an iPhone. And I remember like watching her Google something on her phone during class once and just being like, wow, how useful, And it's so funny because now in 2025, like I live and die by my phone. I don't even use my computer. I use my computer for work. And I don't use it for anything else. And when I hear that somebody uses their computer for like internet searching, I'm like, why? Like it's so the entire like foundation of technology has changed in that 15 years. Um, but then also I think it's so important to think about how, like you said, we use our devices for support for all kinds of things. We use them for memory support. We use it honestly for cognitive support. Like we look up like how-tos.
Mhm.
The other day, my friend said, used the term like it's too much to bear. And this was in writing, and then like BEAR. And then they were like BARE. And then they said, oh, homonyms. And I was like, hey, those are homophones. And I Googled it, to be like, is that a homophone or a homonym? Um, and then, yeah. And then I corrected him. But, I had to look that up. Like I had to support myself to look that up. Now 15 years ago, like that wasn't even something that I would have considered doing. I didn't have access to all of that at my fingertips. So I think there's like really two things at play here. One is those of us who are not getting out of school in the last 5 to 8 years, maybe, might not be thinking about exactly how entrenched we are in our technology. And not only that, but how like complete one piece of technology is for us at this point. Like it is the phone. The phone is the thing that we all rely on. And yeah, sure, we have some other supports, but largely it's the phone. Um, so I think in some ways there's just like a mental shift of having to be like, wait a second, for one, it is so much more normal in the world now to be like have your face in a piece of technology, like that's the sort of stigma of that is gone. But two, we have to also understand, like, especially like as an AAC company or an AAC provider, how used to people are of having everything in one apparatus, which is the phone. So, if you're thinking about AAC, you're obviously, if you're going to do high tech AAC, you're generally introducing another device if it's a dedicated SGD. And you really got to think about like, how is this going to interplay with like their technology use and the supports they're used to right now? And you got to start thinking about how you can build more value into that device use than just verbal communication, or they're not going to use it because that is not how we use technology anymore. We don't have like, you know, the watch and the phone and the list and the calendar. Like we might have some of those things, but I think most of us, half of those are fallbacks. Like largely it's the phone. So I think there's like a few things there. I think that part of the hesitance from SLPs is potentially just like not really making that shift in their head. I think it's really easy also to other the clients that we're working with and think of them as like impaired, and the impaired people use this kind of communication support, not thinking about that it's like the person first, it's a human first, and what are humans in 2025 expecting in terms of technology. And then you've got the whole can of worms of how old is the person that you're working with, because that's a whole added layer where there's going to be very different expectations. So it's a lot to kind of manage at the same time. I think as an SLP, particularly those of us who've been in the field for a while, it's a lot of different like conflicting, I think, ideas that we have to actually make the intentional mental shift to overcome.
Yeah, well, and I'll tell you why people use their laptop, because when you get my age, you have to put reading glasses on. And sometimes I don't feel like it because it just makes me feel like I need this other, and it's not like there's anything against glasses. I just don't, like, it just irritates me sometimes if they're not right there. So I have to make it bigger so I can see it. That's why.
Oh, Renee, just 2 nights ago, I was reading in bed and my husband rolled over. He looked at my phone. He said, "Wow, that's big." He was like, it probably takes you like 4 swipes to get through one page, huh? I was like, I need you to not speak to me anymore. Go to sleep.
Well, when you're talking about technology use, my mother-in-law, she's passed away. It's been almost 2 years now, but she was 79, but she was on as she called it, the Facebook, because, it was a way for her to reconnect with her old high school friends. But she also loved a good pet video, a good, like dogs that were in wheelchairs. Like that was her jam. To watch her use it was hilarious because my son would go, Granny, you don't have to hit it so hard. You just touch it. You don't have to like shove your finger through the screen. And then my father-in-law, we were at my niece's graduation party, and he's trying to show one of her friends this puzzle that he had done that was like extensive and wonderful. And he's scrolling up and he's fixer. And we're like,
Yep.
wow, that's a lot of effort because it doesn't really work out.
Well, and these people, and just to clarify here, no neurologic impairment, right?
Well, my mother-in-law had Alzheimer's, but she would have done that either way.
Right.
Yeah, but he did not. He's just, he was in his 80s, and that's just how he did the thing. And we see that, we see some people that do that, and we have to kind of like coach them into, you don't have to be so aggressive because you're going to break the screen.
Yeah, I mean, this is a great tangent, actually, that we did not do the first time, that I would love to just comment on here really quick. So I think another thing that I see SLPs sort of make a mistake on when it comes to AAC is if the person isn't operating it well, like what you're describing, they're like having a hard time selecting an icon, or like I oftentimes would hear about like the finger touch pressure, like how long they should be touching it or how hard. And what they would be doing is they'd be either touching it too long or too hard, and it wasn't selecting. And so the SLP oftentimes would so quickly be like, so I don't think high tech is appropriate for them. And I was always like, whoa. Like,
that's a big jump.
Yeah, like we do have to, like what you said, we do have to actually coach interaction with the piece of technology. Like it isn't just about can they find the right word or can they speak their message or whatever. Like there are precursors to that are like being able to make the selection, and that's not necessarily intrinsically there for a lot of these folks who haven't been using technology. So like you do actually have to sometimes, like I would literally hand over hand, like touch, to help them understand that like you have to touch it and remove your finger, and this is the level of pressure that you're needing to touch it. And those people would oftentimes figure it out, but so many people were so quick. So SLPs are so quick to say like, oh, they just can't, they can't select an icon, and I just think that's so important to think of too, when we're thinking about that like difference in technology comfort.
Yeah. And also like, I think for some people, it might be like clinicians, I think there's some fear in maybe they realize their skill set isn't where it needs to be. And this continued perfectionism that we need to stop with. You need to understand that there are lots of different devices. There's lots of different companies, but they're most often will have an SLP either do a virtual training or an in-person training. It can be a group like team thing if you're working on a team of SLPs, or it can be individualized training. I know you all record things as well that are accessible on the website, and other companies have done the same thing. But that's another way that you can not necessarily take up your CEU budget or, feel like you have to go to the, I always say this, is it the ATIA conference? Assistive Technology. Yeah. I think people think, oh gosh, I can't afford to do that, or my workplace isn't going to reimburse me to go to this state convention or whatever. You can get these for free or relatively inexpensive depending on what your needs are.
Yeah, my team does. I mean, we do live demos. Like we send out a device, we get on Zoom with you and we walk through the device with you. We talk about your caseload. Like we can show you things exactly like we're talking about today. Like, if you say, yeah, I have a lot of aphasia on my caseload, we're going to say, okay, let's talk about all of the different ways this device can support a person with aphasia. And it's not just selecting icons and having them speak. There's so many ways to support things like comprehension or cognition on a device like this. You've got visual scene displays, which are well known to support comprehension, different types of pictures. Like, I think if I'm thinking about like what are the features of a device that are important for specifically, let's say, comprehension, visual scene displays, different types of pictures for sure. Like, I think sometimes SLPs, for the sake of science, like want to be, they're like, well, the evidence says, that like real life pictures are the top thing that people recognize most, so, and like, it's a great place to start, I think, oftentimes is like, start with, stuff that's well supported in the evidence. But it's also really important to take a really personalized approach when it comes to AAC too, and figure out what speaks best to your client. So, it may be that for them, a real life picture isn't the best. Maybe it is something like a line drawing. Maybe a picture's too visually stimulating. Some people are going to be more or less bothered by a smattering of different types of icons or images, right? Like, and others are going to be fine with that.
Mhm.
So I think there are ways that we can think about the types of image supports, also the types of language. So like one of the things that our device is really flexible, so we have the ability to like what the thing under the image, what the device is going to say, or even just say on the screen, can be whatever you want it to be. So it could be like a full sentence, it could be a phrase, it could be a sentence. It can also not exist. So there can just be only pictures. But I think sometimes that has made a huge difference too when it comes to comprehension. I mean, people, especially if their image recognition isn't great, they're not going to be able, or not image recognition, but I guess semantic comprehension of images is probably a better way to phrase this. They're not always going to be able to pick the image that they want. So oftentimes, like, even if reading comprehension is impaired, the combo of like some context in the having a word or phrase and the image can kind of like bridge that gap. It's enough to kind of overcome the impairment kind of on either side. But you got to figure that out. You got to tease that out. Do they, is a phrase better for them because there's more context? Is it a
Mhm.
keyword that they need? Is the keyword going to do it and a phrase is too much? Do they actually need a whole sentence? There's so many different kind of like nuanced,
Yeah.
changes that we can make. And I really just encourage SLPs to think about like how it's going to take you a long time. Like, I just want to say that it's going to take you a long time, and you should be taking that time to really figure out exactly that setup that is actually going to work for your particular person. And don't be afraid to try things, even if it's outside of what you think you know.
Yeah, and I think that's kind of where you've headed is where, the ways that AAC can be modified or adjusted throughout these different disease progressions, particularly when it comes to degenerative things. We get a lot more patients now with Parkinson's disease, with PPA. They're going to have changing communication needs along the continuum of the condition that they're experiencing. And so how are some ways AAC can be modified or adjusted? Because I think that's another area of fear is that, you get taught this basic, get the device you think they'll need in however many years, right? Because we only
Yep.
get how many years? 5 years before
Yeah,
we get
5
to use,
years.
before you could get another device. So I think that's another area where it can be a little bit intimidating for people.
Yeah. So, I mean, for me, and it's always interesting, working for an AAC company, but also being Beth the SLP, there's, um, I have my own personal kind of like opinions and just like my clinical knowledge and expertise in what I've done clinically. I have always really erred with a device on flexibility. Like I want the device to be very, very, very flexible, very modifiable because of that 5-year thing. Um, So, okay, like let's take literally any given patient ever. I mean, they can either get better, ideally, that's what you're working toward. They can get worse for whatever reason, degenerative condition, new onset, something, whatever it may be. Um, and we want to believe that we are going to be able to continue to use supports that they're familiar with.
Mm-hmm.
That's the goal. That would make sense. So I really like thinking about and kind of training SLPs to think about both directions that you could take a device. So you have the original setup for them, whatever you did your training with them. You did really, like I said, good work in kind of long-term thinking about what's going to work for them. You've tried things, you've got it. It's good. Now I want you to think about what are ways that I can make this device more complex in the situation in which complex is the way to go. They're getting better. They need more options. They are getting maybe less distractible or more cognitively able. Their memory is getting better. Their working memory is getting better. So they're able to go through a more complex, sort of deep device and get more of what they say, what they want to say out. Or how do we make this simpler? And we want to know that we can take a device from the place that it is and without an abrupt change. So like, I'm not a big fan of, personally, not a big fan of like switching language systems. Like, I think that when somebody is used to a language system, I generally want them to stay there. I don't really want to teach them a new language system. So how can I make it more simple? And obviously that's removing choice or spreading choice out, making icons maybe bigger so there's fewer things on the page, maybe adding layers to the device so that, again, there's fewer choices. So there are ways to do that. However, something that I love to coach on is that there are times with a degenerative disease where you're going to start one place, ideally before the person even needs the device so that they can learn, and get it set up in the way that they want that device set up. And then you're going to sort of slowly simplify, slowly make it easier to use, whether it's from an accessibility standpoint or cognitive standpoint. But then there may be a point in which they can't use it really anymore independently. And we start to rely more on the communication partner to assist. Mm-hmm. And for a while, I think we assist using the device in the setup that they're used to. But again, there also then ends this point of diminishing returns where they really aren't able to use that device, even with the person's, kind of assistance anymore. And in that case, I actually recommend switching the setup of that device from setup for the user to set up for the communication partner. Because now you're going to probably need it for things like comprehension. And I'm thinking this is typically what I'm recommending with like severe dementia, Alzheimer's, things like that, where this person is not going to understand what the device is for anymore. So what we're going to do is we're going to move it into the way that the communication partner's brain works, the setup that they would like it to be in, so that they can use that device as a picture support for comprehension, cognition, even safety support, with visual, having those visual image supports and things like that. And I think that's a flip that people oftentimes don't think of. It's sort of like once the user stops being able to use it, it becomes obsolete. But I actually think we have the opportunity to then kind of almost flip the device on its head and use it the other way around entirely for comprehension. So I'm actually a really big fan of AAC for degenerative diseases for this reason, because I think it provides an entire layer of support that I can't think of another way that it exists other than something like a device.
Well, yeah, because a lot of times what you see and you did home health for a while, what you see when you go into someone's home, either the patient knows they're struggling or the caregiver is kind of taking over the role of communicator. They put a lot of Post-its up with like sequenced task, or they put Post-its up to remind the person to take their medication. They put Post-its in the bathroom. So yeah, like you mentioned safety, but safety falls in the bathroom, right? How many times did I get called to the emergency room to do a swallow screen on someone who had a fall in the bathroom? All the time in
Yeah.
acute care. Medication safety is a big thing. Unfortunately, some caregivers can't be there 24 hours a day, even if it's needed, because it's just not real life. They have to work to provide for their family and for the care for their loved one, for the insurance, medical insurance for their loved one. And I think, that to me, that makes perfect sense, because you can also use it for things like forced choice. If they can't auditory comprehend what you're saying, do you want coffee or tea? You can show a picture of coffee or tea, or whatever their preference is. And I think, again, that is brilliant to me. It makes total sense. But my world is always neuro, and I think that's another area where we get crossover from different settings, which is great. But don't be afraid to um, learn more and change, like shift your mindset on how these things can be used. And one of the things we touched on before was shifting the prioritization of the severity of the disease versus the impact of the disease or the injury. And that is a mindset shift. And that's kind of what we've been alluding to. And so, how do we accomplish that? What are some ways in which we can do that?
Yeah. So another thing that I hear a lot in sort of the argument against AAC for somebody is like the person's communication is too high level, or their expressive communication is too good. And that always, I feel like every time I hear that, I have like a little bit of a red flag happening in my brain. And it is like, well, then why are they in speech therapy? Like, how did they, like, clearly something isn't where it's supposed to be. So like, I think that we tend to do this thing where we rate by severity in this very like objective sense of like, this is what you scored on a test, or this is how much I can understand of you, or this is what I am describing as complex versus simple. That's something that like I like go back to my CF and think about when learning to write goals. And this was in inpatient rehab, and it was like, be able to communicate complex needs or simple needs, and how often, like, because of the severity of somebody's injury or illness, we would write for like their long-term goal to communicate simple needs. And like, now I'm like, what do I mean? I stopped at simple needs. That's very scary in thinking about that now. But I also think that's a different case than we're talking about right now, because we know that person might need AAC if we're only going to simple needs. It's the folks that their communication is quote unquote too good. And I think what I would like to see a shift in more is talking to the person about what kind of communication they want to be able to do and what they actually are struggling with. So, we know like the life participation approach to aphasia. We know the WHO model. We know we've got the injury or impairment and the actual physical body impairments. And then we've got all these other factors, and these influence participation. And when we think about the impact of someone's communication impairment, we want to be thinking about what they personally find important, or the way that they would feel like themselves. There's so much like mental health involved, I think, in this. And so often we're so quick to say like, oh, I think you're communicating good enough. But that's such an interesting thought if you like think about yourself. And again, I think this is where it's because we're othering this group that we're working with, where like if you said, Beth, like, I think you're communicating good enough, I just, I'm not going to do anything to help you get your communication to where you want it to be, or support your communication to where you want it to be, I would be like, freaking what? Like I would be so just like, what do you mean? Like I have had this way of communicating for my entire life. I am a verbal person. I like having deep conversations. I know I said it last time, but I have a almost 15-month-old. My word retrieval is just in the trash. Like, it has just been terrible probably since I was pregnant. Um, and it literally impacts me. It impacts the way that I feel about myself. Like, it impacts my confidence going into things like this podcast or going into a meeting at work. And yeah, can I communicate well enough? Sure. And I'm not advocating that I need AAC. However, I am advocating that I need assistive technology. Like, if I did not have my little Google machine in my pocket, I would not be able to communicate always the things that I want to communicate. As it is right now, I have to circle back sometimes to be like, hey, what I was trying to say was blah, blah, blah. And I just think we need to make that shift, that we need to listen to the person that we're working with about how they feel about their communication and what type of communication is acceptable for them. And then we need to look at severity of that thing. So let's say I communicate fine, except for in meetings at my job. And, I'm a senior manager. So the people that I'm having meetings with are people high up in the company. These are meetings that are fairly high level. I need to be able to participate in a particular way. Let's say I get to those meetings and my word retrieval goes completely down the drain in those meetings and I can't really communicate anything there. I personally, as Beth the SLP, not as the AAC rep here, say I would make a case that I could recommend AAC for that person, because in that situation, which is important to them for being in their life, their communication is at least moderate impairment. And it's the thing is, like, we got to look at the situation that's bad, not just the overall situation, because that's not fair. That's me putting my expectations about your communication on you. I need to be looking at your expectations.
Well, and one of the things we touched on too was vocabulary. Some people use certain words, whether it's a regional thing or it's something that was learned in their environment growing up. There's certain vocabulary words that people use and other people don't use. And so we go in and we program this device for a patient with pretty significant aphasia, and the word isn't something they use. Guess what? They're not going to use it. I say cupboard instead of pantry, and my kids laugh at me all the time. And I'm like, I didn't grow up saying pantry because my grandma said, go get the whatever in the cupboard. And so I say cupboard, and my kids are like, you sound like a little old lady. And I'm like, I don't care what it sounds like. It's a word. Google it. Because if you put pantry on mine, would I know what it is right now? Sure. But would I use it? Probably not. Just like for food, I'm not going to want McDonald's because I'm not eating it.
Yep. Well, I was going to say dinner and supper are an interesting example of this, dinner and supper, because those actually mean different meals to different people, which is a very
where I live and further south. Yes.
Yep. That's exactly
my grandmother
right. So
never said lunch. She would have died if someone said lunch. She'd have been like, oh, wow, you're highfalutin.
Well, and my mom calls dinner supper.
Dinner was lunch and supper was supper at night. Yeah.
And and that is so important too. Like, I think that's a great one, because it's not even just like a different word for the thing. Like, it literally means a different thing, where, there's other situations where, like, maybe pantry and cupboard might mean generally the same thing. You just have a word choice difference. They also might mean different things to different people, but yes, that is such a great point. It is, again, that personalized approach of literally being like, what do you call this thing? I remember this from at a LARC kit. I'm sure everybody in here knows what a LARC kit is. LARC kit is still like probably my favorite tool. And actually, I was just thinking for my near 15-month-old, like, I should make a little baby LARC kit for him for like when we go to dinner and stuff, because it would like entertain him. But that was what I literally in my head called it, a LARC kit, which is really funny. But I remember holding up like the washcloth to people, and I call it a washcloth. But man, oh man, there are so many words for that item. There's rag, wash rag, washcloth, towel. There's so many different things, that people call this. And that was a big, like, very cool eye opener for me early in my career to be like, oh, okay. Like, I have to accept several different answers here. And it's that same mindset that is, what's going to take us into, like, how might we use an AAC device in a different way. It's that mindset of being like, okay, there is no one exact way that this is supposed to happen. Which means great news. You don't have to be perfect. You just have to try and, do some investigation and sleuthing.
Yeah. Well, like today when I had a tank top on this morning because it's beautiful here. And um, I said, I need to go change my shirt. And then I realized when I'm looking at my shirt, my grandmother would have called this a blouse. This is not a shirt. Yeah. My grandmother was very like Southern Belle Emily Post kind of thing. So very proper, which is a whole different podcast. One thing I wanted to touch on was because we've talked so much about like validity of how we use AAC and just the contributions it makes to overall communication. Would you use AAC for practice? And this is like one of my favorite questions to ask you.
Yeah. So I very much feel that communication is tied to our sense of self.
Yeah.
And um, because of that, I think that there's a few things that we have to think about that go into our sense of self. And that includes like sense of control, self-advocacy, sense of independence. Um, I still remember I had a horrible job once. Which I will not call out, but it was one of those, everybody's had that therapy job where
Oh,
they're
yeah.
like, within like 2 months, you were like, nope, this was mine. But one of the things that we learned in the orientation was about cruise ship syndrome, which I'd never heard of before. And I don't even know if like it's a thing that they might have made it up for this. I don't even know. But the idea is that nobody likes to be helpless and not have any like part of doing of things. Like nobody wants to just be on vacation all the time. Like it might sound nice to be like, oh, my mom I just take care of her and she doesn't have to lift a finger. But like that is not really like good intrinsically for us as people. We like to feel useful.
Yeah.
So when I think of AAC and practice with an AAC device, that's where I go. I think when someone has had whatever it is that has happened to them that makes them need AAC, they probably oftentimes need or have recently in the past or at some point needed a lot of other support. They're being poked and prodded and their schedule is not theirs. They're being physically picked up and moved. They're having toothbrushes stuffed in their mouths. They're being done to all the time.
Yes. Mm-hmm.
And we've all had those folks who like just shut down on us in therapy. They're just like, I am done. Like I don't want to do more therapy. And I think that one thing that we can do here is think about both in the therapy we're already providing, like even before the person gets to this point. But at that point as well is how can we provide them a sense of control and a sense of independence and usefulness to themselves? And it's that same, thing that we think of like, scaffolding appropriate cognitive tasks. Can someone sort the silverware into the silverware drawer? Like, can they dry the dishes? Could they fold the laundry, but maybe they can't do laundry? But I think AAC is another place that we can do this. Maybe they can practice whether it's their home exercise plan and it's just practice on their own. Or maybe like they need a break from therapy and they can practice using the device that way. Or maybe that's just the way that they want to use the device. They want to have that model. They want to read it. They want to go through and play with it from like a technology standpoint where they're actually like practicing moving through the device. Those are all cognitive skills. Like that's working memory, that's executive function. And I think that is a completely valid use of AAC. It does a couple things. One, it gets them more familiar with the device, more comfy. But it also has them feeling a sense of control, and also that they are leading their own thing. They're not being done to in
Yeah.
that moment because they're doing it themselves. So I personally feel like all I don't I cannot find anything bad about using an AAC device for practice. I think if anything, it opens a door for more communicative use of the device. And oftentimes it is the door you have to open to get to that. So if you have to start there, by all means, start there and have the person be using that and feel positive feelings around that if you're wanting them to get to using it communicatively.
Yeah, and I think the 2 worst things for me is when I'm able to get a trial device and I find out, this is someone who is reliant on a caregiver. And my last job, I was working with adults with intellectual disabilities and a lot of adults with autism or Down syndrome, and they were reliant on someone to actually physically charge the device, but also
Mhm.
hand it to them. And so a lot of times what would happen is I would go over for my visit and the device wasn't charged and or the device was in a locker or the device was in someone's office or in a drawer, not
Yep.
even in the room where the client was. And we got a lot of that. It's like, oh, well, today he woke up, he was talking, so he didn't need it.
Right.
And I'm like, that's
Yeah.
no. So again, we have to reframe other people's mindsets beyond just clinicians. And that's a great way to use it for practice because one of the things we train caregivers to do is to customize the device.
Yep.
Because when we're gone, when the trial is over and they've got their permanent device, they may not need us all the time.
Yep.
It helps to know that they can put a picture of someone familiar to them on there. So, like this one particular young man I was working with had a preferred caregiver at the day support program he went to. And when he wasn't there, his day was not great because
Yep.
no one was, well, one, no, he missed his buddy. And two, no one would give him his device when he wasn't there. And it was really frustrating because he's the only client I've ever had who day one we gave him the trial device and he took it like, thank God you idiots finally figured out that I know how to do this.
Yeah.
And he started using it immediately. And I mean, using it well, navigating through menus. And it was a trial device. It wasn't even set up for him yet, but he knew how to get to the page to tell us he was thirsty and wanted coffee because he was a coffee obsessed person.
Yeah.
But it was crazy to me to think that he had gone through 2 or 3 other SLPs in the same type of setting before he got to me. And I went in and I'm like, this guy, I think he might need a trial. Let's
Yeah.
try it. What's the worst that can happen? He doesn't use it, right? And I tell you, I've never seen anything like it because he clearly had had one in his past, and he was like, his look on his face was like, I'm glad you figured it.
Yeah. Yeah, I mean, I think always try is like kind of my so many SLPs will be like, you know, should I try, a device with my patient? And I'm like, yeah. Like if there's even any thought in your brain that like, hey, there's a possibility that this would support their communication, yes, you should for sure be trying. And to your point, like training caregivers and making that really part of your actual implementation and therapy plan, making sure that the caregivers and communication partners are adequately supported to be able to support your client is just so, so, so meaningful and something that I think we undervalue and overlook a lot of the time. And again, I get it. Like I've been a clinical SLP. Like it is hard to get access to those people all the time, for sure. But like really taking that very seriously though, like that you really gotta try and you really gotta think of it that way. Um, and like like at the company that I work for, we offer remote training for that purpose. Like we know that as the SLP, it's going to be hard for you to reach them. But so we will do it. But so using those resources too, using the
Mhm.
resources that exist in the company that you're working with and things like that, to help make sure that you're providing this person like the whole kind of realm of support that they actually need. Um, Boy, I had a patient once that I gave her a device. She'd been in like a sniff for like 6 months at the time, and gave her a device. And I asked her what drink she wanted, and the nurse was in there, and she picked Coke. And the nurse said, oh no, you always have Diet Coke. And she was like, Coke. And the nurse was like, no, 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 she likes Diet Coke. And the lady was like, Coke, 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 Coke. And I was like, I think it's Coke.
Yeah. And that's how this guy was. He wanted coffee and he wasn't supposed to have it. But the thing with him was that they had tried using like a picture book. They had tried using just picture boards, and he wasn't interested. He had a lot of tactile sensory stuff, and he didn't like the way it felt. So he would, if you gave it to him, he would just throw it. And it's so interesting to see how people don't pick up on those cues, because it's like that horrible hospital communication board. They give it to the patient. First of all, it's on yellow cardstock. That's the weirdest color to me. It all has black and white line drawings, but on the other side, it has color pictures, and there's words and phrases, and they're all on this one big sheet of, it's bigger than a legal piece of paper. And I looked at it the first time I saw it, and I went, I don't think I'd be able to use that. Just like if you woke me up in the hospital and you said, what is today's date? I don't know. I'm going to look at I might be able to get close, but if I've had anesthesia, if I've had surgery, if I've, had a stroke, God forbid, anything, right? You're in the hospital for a reason. I was in the hospital last year and they came and asked me that. I'm like, I can tell you other things. Let me tell you other things.
Yeah, well,
it doesn't count towards my
orientation. Yeah, I love that point though too. Like especially now. I mean, I literally work and I'm at a computer all day, and I don't ever know what day it is. Like those are things that we do already rely on external aids for.
Yeah.
And you're right. Like I think I love that you're bringing up too the difference between there's sometimes this error also in this idea that if the person isn't using low tech, they're not going to use high tech. Yeah. And I just always think this is so funny. Like when I hear this, like it's not funny. It's sad that this is like where people get stuck. But in my brain, it's so funny because I'm like, you could take a room full of people, and I do this with my class every year. I'm like, I want you all raise your hand if you use your phone calendar for like due dates for things. Like, is that where you put your like appointments and your due dates for things? Raise your hand for that. And like half the people will raise their hand, and I'll say, and then how many of you use a written planner? And that's what you use. And the other half will do that. And then I'll say, and how many of you do some combo of both? And like, that means you can never really rely on either one, which is me. I'm that person. And like usually like 3 or 4 are like, and I'm like, this is such a great example. Some people like a lower light tech option. Like that is more salient to them. It feels more appropriate for them. And then other people really like the technology thing. And AAC should be the same way. Like it isn't like you have to move through low tech to get to high tech. You have to be like, hey, there might be reasons. And your point is so good. Like didn't like the feel of it. Again, probably had access to high tech in the past and is like, what the heck is this stupid piece of paper, and and then like you said that, those hospital boards, they're not organized in any way that makes sense. A high tech system has so much more capability to be actually personalized. So I'm always shocked when people are like, well, I don't want to try a device because they haven't used low tech. And I'm like, if I was reliant on using a calendar to show that I could have my phone, I'd be screwed. Like,
yeah,
I just get fired.
It's the pain strip in the hospital. And it's got the colors of the face, but it's also got the expression of the face.
Yep.
And there's been so many times when I've gone into a patient's room and we have to do the pain assessment and say, on a scale of 1 to 10, what's your pain level? They look at me like, oh, I don't know what that means. And so I got to the point where I've had patients like try to mimic the face, which is so funny to me and like endearing in the most endearing way. But then I'll get the people who like, they don't understand it. So I'll say, 0 is nothing. You're fine. It's normal. 5 is like, it's hurting pretty bad. I might need to take some Advil. And 10 is like you're being stung by bees and you're also on fire. And everybody starts laughing at that.
Yep.
Because we get these patients and they're like, it's a 12. And I'm like, yeah, not. You're sitting there eating a bag of Cheetos. It's not a 12. It's not. I've had 2 kids and a surgery. It's oh man, but I have one more question that I want to ask you as we wrap up. And I know that you're a big proponent of using things in the outside of the box way, which is one of the reasons I think you and I have always kind of clicked. But would you recommend consideration of AAC for people with fluent aphasia?
Yeah. So again, definitely I am like an err on the side of yes, always try. I think that again, if we're thinking about strengths and weaknesses and like support opportunities when we're thinking about AAC, it's easy to answer that question with a like for sure we should consider it. Now will it will it work? I don't know. I'm not sure. I mean, it definitely isn't like because you're considering it, everybody should have an AAC device. That's not at all what I mean. Um, I think with fluent aphasia, there are the barrier to like getting to do therapy with these folks is so high. This is one of the groups that, and even as a person who really like, I love aphasia, I feel like I understand aphasia. Fluent aphasia is like one of, especially like Wernicke's aphasia.
Yeah.
It is just, it's like you're climbing over a wall to even get to the part of where you're actually doing any therapy. And so much of that is because the comprehension is just so poor. Between like the comprehension and sort of the impulse to talk constantly, it is so hard to actually have anybody participate in a therapy task because they don't understand that you're telling them to do it. They don't understand the task and they won't be quiet oftentimes long enough for you to get them there. Something that I think is useful about AAC in this situation is that you've got that visual support. So I have found with these folks about the only way that I can usually get them to stop talking, like to let me try some contextual comprehension support for them is to use like the stop hands. Okay, stop, 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 stop. So we know a visual support is helpful. So having something like a device where we might even be able to use it for like just the visual support of like stop or quiet. And then the ability to show a model repeatedly. So you're saying it and you're showing the model repeatedly. I have found that, these folks, because of their comprehension, they have to see something multiple times. They have to see it as the model. And oftentimes that is what will help them understand the task because the words aren't going to do it. And the device helps you be able to do that. I mean, you can even do visual supports like recording a video in the device. So you could have them see that video, even so it's not just something that they're, doing in your session. Because even trying to have them do like a cognitive activity, my favorite therapy item is a deck of cards. I always joke in my class that like you could put me in a room with any person with any communication impairment ever with a deck of cards and like I would be able to do an hour of therapy.
Magazine. That's me.
Yeah. So, I like would give
Sometimes
them,
that's all I had.
well, exactly. And like a deck of cards is so useful. You just put it in your pocket. But yeah, so like I would give them like, 2, 3, 4, 5 in the same suit. And I would mix it up. I would lay it out. I'd show 2, 3, 4, 5. Make hands, show them. There we go. Pick it up, mix it up. 2, 3, 4, 5. Show them again, mix it up, hand it to them, show them that I want it on the table. So like I'm using this like visual and gestural cue. And the thing is that you can do things like that on the device. I could record doing that kind of sequencing. Yeah. And then have them use that as a home exercise plan or have their caregiver be able to use that or even to show how I'm supporting comprehension so that their caregiver can see it because they're not at my session and then they can look at it when they get home and they can replicate it. So like there's all these like outside of the box ways, like you said, to think about this. It doesn't have to just be like this is directly going to make you talk or this is directly going to make you understand, but it might be that like this is my conduit to you being able to do this type of activity somewhere else. So, yeah.
Wow. This is a power-packed episode to me. So I'm so grateful for you coming on and I think your word finding was fine because I do the same thing. And a lot of times what happens with me is that when I'm spinning my wheels, I have these like the taglines, and people say, "Oh, you get rid of the tags," and I'm like, well, sometimes the tag helps me stop, like a pause to get my thought, because my brain is always like, "Duh."
Yeah. Yeah, no,
So
I really just surprised myself with conduit. Like, I was like, oh, look at that. That was a word that's not a word I was planning to say, but it was the right one.
I used the word truncate yesterday, and I was like, where
Oh,
did that come from? GRE moment. For those of you who are younger who didn't have to take the GRE, we did, and we had to know all these words.
yeah.
Nice.
Yeah, like once every 3 years, somehow hypotenuse comes out of my mouth in some like appropriate way. And every time I'm like, what? Look at me go.
Well, Beth, thank you so much. And we appreciate you being here, and just keep on keeping on doing what you're doing, because the work you're doing is really valuable and really important. And I appreciate you being with us.
Thanks. Thanks for having me.
Of course.